Hello and good morning and welcome to this symposium here at the ESC in Barcelona, devoted to screening and screening technologies with particular focus on atrial fibrillation and arterial hypertension. I would like to share with you my perspective on the role of screening technologies, telemonitoring in the field of AF, and hypertension with an extension to heart failure and home care, because I believe this is one of the key elements of the future of cardiovascular medicine and beyond. And I will share with you my key arguments, and then at the end of my talk I will review with you a very, very brief case that I think supports that perspective. It's all on access to care, easy, fast, solid access to care, and improvement of outcomes by data analytics. And we know from various clinical trials and studies that high blood pressure and atrial fibrillation are really a dangerous couple. Does it make sense to take a look to technologies that put both states of disease, so to speak, in focus, not limiting it to arterial hypertension, not limiting it to atrial fibrillation, but combined technologies to have a more complete picture of where the patient stands. And it is well known, and there are good data, that both states of disease support themselves in the form of the classical vicious circle. So intervening, and the case gives rise to that perspective. Intervening on one side is not enough. You have to intervene on both sides to get the benefit for the patient. Home care and self-assessment will be key elements in the future of medicine. With, as I said before, with a regional aspect from European, North American perspective, but also with a global perspective. We have the privilege to have Ben Friedman with us, the head and brain of AF Screen, who's taking care for worldwide screening activities in the field of atrial fibrillation and more connecting to the world of hypertension. So Ben is also on the same track in order to get a more complete cardiovascular monitoring, screening, monitoring, and treatment. Treatment is really important, and I will come back to that point during my talk. Again, just measuring a biological signal is not enough. It does not change anything. It's the connection of the measured biological signal to a therapeutic intervention. That means that single point assessment in patients will not really help. But you need to be repetitively on the patient path continuously. Long-term access, they are relevant in chronic states of disease such as arterial hypertension and atrial fibrillation. We will take a quick look to the technologies, because technology is very, very important in order to apply the opportunities that are given by technologies in the best meaning for the patient to get the highest compliance, the best acceptance, and then at the end the best results. And last not least, I just will go to one of the case examples. This is to remind us that when we see diagnosed atrial fibrillation and diagnosed hypertension, we just see the peak of an iceberg, of the iceberg. There are millions, if not hundreds of millions, patients around the globe with undiagnosed hypertension and atrial fibrillation. And again, the view to technology. Now we have technology in our hands to change that, to increase the size of the iceberg, which is about above water level, and it will result in reduced stroke rate, in reduced heart attack rate, improved quality and quantity of life for the people affected. There's one clear message from this slide: 50% of the patients, regardless in what situation you look, have undiagnosed, that have hypertension. It is undiagnosed. If it's undiagnosed, it's also untreated. Looking to the field of atrial fibrillation, we see that hypertension is one of the key elements in the field of reversible risk factors that needs to be addressed in patients with atrial fibrillation. And we know that hypertension control in patients with atrial fibrillation adds to the benefits that can be given to patients by advanced rhythm control strategies. So the advanced application of catheter ablation in patients with hypertension and atrial fibrillation is a combined package that we should offer to the patient. Just ablating the patient and then putting him or her on the road is virtually not enough. But the figure also shows that multimodal activities need to be rolled out in order to gain maximum benefit for the patient, as atrial fibrillation is driven and promoted by a set of comorbidities. And important is that many of these comorbidities can be reversed if we take the right and appropriate action. Home care applications will substantially increase. I've made that point already a couple of times. It will be telemedicine-capable technologies to be connected, and that refers to the point that I've earlier made. Just measuring a biological signal does not change anything, but transfer of the message into a working and feasible system for structured data analytics and transferring the data analytics into change of treatment is the strategy that will at the end make the change and improve outcomes. Yesterday, we have seen the eBrave trial. eBrave was one of the late breakers. That was also a trial on the detection of atrial fibrillation. It was also an app-based trial, so technology, smartphone communication plays a key role. And not surprisingly, the eBrave showed, if you look closer, you see more. I mean, Ben, I think it has been shown in all studies with a different degree, different intensity that relates to the technology used. With continuous monitoring, you see different things as compared to discontinuous monitoring. With discontinuous monitoring, you can cover longer time frames usually and get repetitive measures. And at the end of the day, an intense discontinuous monitoring over longer time gets over the thumb comparable results as compared to continuous monitoring, let's say for 21 days. Connection to virtual care is the other element that I see in the future. I see digital technologies. I see intense self-assessment that goes far beyond the self-assessment opportunities that we currently offer to the patients. Connection to digital care centers, virtual hospitals. We have opened up a digital care center already in Berlin, and we will open up self-assessment centers for cardiovascular care in the next 12 months, where the complete initial onboarding and evaluation is done by the patient himself or herself. And it will, you may think I'm crazy, but I say it will include technical investigations that patients will do on themselves, such as ultrasound. It's all technically all feasible. I do not want to go into too much depth of the discussion, but think back 20 years when we saw 75-year-old people standing at the airports, and we believe they will not be able to onboard with the computer settings. And now You go to the airport, buses of retired people are standing there and onboard themselves the plane quicker than I can do it. So the general argument, no, people may be too old or maybe even not smart enough to go in self-assessment is absolutely not true. And the technologies that are provided, complete technologies, blood pressure, rhythm, weight, temperature, facial viewing, all these elements will be put together and will substantially improve. I'm getting a little bit over time because I do not know, I haven't seen Jérôme, so I take another 1 or 2 minutes. Home care with blood pressure, there are good data that as compared to in-hospital assessment, the benefits are in this meta-analysis more pronounced for home care as compared to usual care. And it's interesting, the difference in that study, but the meta-analysis from 2011, it's not really focusing on up-to-date and modern technologies, does not include telemedicine as one of the key elements. If telemonitoring was applied, the benefits of home assessment were substantially higher as compared to non-telemedicine connected technologies. The quick case that I have prepared, I've recently treated a 52-year-old patients with highly symptomatic atrial fibrillation for a year. ERA 3, the man was a little bit obese with a BMI of 32, no other comorbidity. Antiarrhythmic drug treatment was done with flecainide that was not effective, so it was a class 1A indication according to ESC guidelines. He underwent catheter ablation with pulse field ablation. Pulse field ablation, this is not from the particular patient. This is an example from the work of Vivek, but it was the same technology. Pulse field ablation will absolutely change the interventional therapies in patients with atrial fibrillation because it's safer and it's substantially quicker as compared to traditional radiofrequency ablation. Why do I share it with you? Because it's important for follow-up and home care. We will do these interventions on an outpatient basis in 80% of all cases in very few years from now. Then the complete onboarding process, the onboarding pathway, and also the follow-up of the patients will be completely different as compared to an in-hospital setting. That means that we need technology that allow us to stay with the patient and to monitor rhythm and blood pressure and other parameters after the ablation intervention. And when it comes to healthcare economics, it will also be able to save a substantial amount of money if we go onto that path. So the investment into technology for home assessment is by far lower than the money that can be taken out of the cost bill when the duration of stay will be substantially reduced, and it's just a single day treatment. So he underwent PFA. He continued to have symptoms and palpitations, so he was not happy. I said, okay, lose weight, then it will get better. But you know, with losing weight, it's always a problem. They say, yes, I will do it, and the execution may be so-so. During in-office follow-up, he had sinus rhythm and a blood pressure of 125 and 80. We equipped the patient with a blood pressure and atrial fibrillation, the complete monitor for home assessment, and diagnosed arterial hypertension, and the episodes where blood pressure exceeded 160, 170 were the ones that still triggered episodes of atrial fibrillation. Atrial fibrillation was also documented with the installation of antihypertensive treatment. The patient was free of any further symptomatic episodes. My last slide is how we see the future of medicine in that setting. digitalization and apps, self-assessment will play a key role, connecting to digital hospitals. The patient is connected, the ones that I shared with you, to our digital hospital, so I don't see him anymore. He is on a virtual path with our centralized doctors in Berlin and small centers for physical access to care that will, to a certain extent, replace the traditional settings in healthcare, will come to improve the quality of care around the globe. Thank you very much for your attention.